This is probably a continuation to the two sessions by Dr. Megdi about non-invasive testing, but I'm gonna focus on cardiac CT in particular because I find it's a bit of weakness we have. So we're gonna cover the gaps in knowledge about cardiac CT. Besides, cardiac CT is becoming really important non-invasive testing and it's taking the forefront. Okay, so there are recommendations to advocate cardiac CT as forefront kind of non-invasive testing. I'm gonna mute. So please make sure you are mute. Okay. I'm gonna start with this question as an appetizer. Which of the following is false about cardiac desynchrony? It leads to mitral regurgitation. It decreases cardiac output. Features as broad QRS. Better assessed by echo. The reason for CRT. So, which one is false about cardiac desynchrony? Okay. Any interaction?
I think, Assalamu alaikum.
Wa alaikum salam.
Okay, I think it cannot be assessed by echo.
Okay, so you think D is the right answer because D is false.
Reduction of cardiac output, it causes a mitral regurg, some sort of feature of broad QRS.
Okay. You're right. You're right. D is the right answer. Yeah, because cardiac desynchrony can lead to mitral regurgitation. Yes, by the dilatation and desynchrony in the segment, it leads to functional mitral regurgitation. It decreases cardiac output, and obviously that's because the segments are not contracting synchronously. So some segments are contracting, others are relaxing. So that leads to the negation of the contractile force. So the contractile force, instead of going into the LVOT, it goes into a relaxing segment. So that's a problem, And it features as broad QRS complex, and this is basically the criteria used by the recommendation for eligibility for CRT, which is QRS complex more than 120 or left bundle branch block, right? And that's why we do CRT. The indication for CRT is an ejection fraction lower than 35, symptomatic patient despite optimal medical therapy, and ECG eligibility. There is no echo here, although echo was and probably is going to come back for desynchrony assessment. In this case, that will be called mechanical desynchrony assessment. And in the ECG, electrical desynchrony assessment. Okay, so the echo still has the capacity and has the ability to assess for mechanical desynchrony. Okay, you can assess the desynchrony between different segments. This is called intraventricular desynchrony. You can assess the desynchrony between the two ventricles, interventricular desynchrony, and you can assess the desynchrony between the atrium and the ventricle, and that's atrioventricular desynchrony. So we have three types of desynchrony that can be assessed by atrioventricular desynchrony, interventricular desynchrony, and intraventricular desynchrony. Okay. Okay, next question. Cardiac CT has a versatile techniques provided ample information about all except real-time images of the heart, diastolic function assessment, vessel analysis,
دكتور حاتم اوت ولا الحصل شنو؟
ايوه ما شايفين حاجه.
رح نجاوب قبل ما يدخل لنا.
هو السؤال شنو كان ما شفناه؟
Role of the cardiac CT. All of the following except.
الاوبشن
المذكراها منهم انه assessment of the systolic function. تقريبا الفيزل وول. تاني شنو؟ ما ذكرتهم معايا.
real time.
اها هم 5.
هو طلع ما نحن طلعنا. كده ممكن هو طلع مريم.
طيب السؤال كان شنو؟
ايوه فعلا هو اوت.
هو الاوت ما ده أول سؤال يا ريان كان؟
لا ده تاني سؤال. السؤال الأول كان عن السي ار تي.
السي ار تي كان
مش السي ار تي يعني الديسنكرونايزيشن كان السؤال الأول.
ده حضرنا واي.
I'm so sorry I had technical problem. I went out.
Okay.
So no problem. I will just a moment to get the slides. Okay, sorry. We stopped here, okay? So
Yes.
cardiac CT provides all except real-time images of the heart, diastolic function assessment, vessel analysis of the wall and lumen, valve gradient measurement, and infective بدينا والله infective endocarditis assessment. Aha. Which one is not provided by cardiac CT among these 5 options?
I think the wrong answer is
هم اللي it can provide us with real-time image of the heart. It can show us the visual analysis of the wall and the lumen. Also, it can be a part of effective endocarditis assessment.
Very good. So you narrowed it down to 2, B and D, right?
B and D, yes.
Okay.
Best of 2. مساعدة يا شباب.
Great. That's a great help.
Gradient measurement.
Yes. Gradient measurement. Because, you know, in CT you have functional data. Okay. I'm going to show you now. In CT, you can have functional data. You can have the heart in real time. The heart is contracting and relaxing. And once you can have that, you can employ software for the assessment of contractility and relaxation and all of that. So you can have an idea about the ejection fraction, the volume, the diastolic function. The only thing that is not among the armamentarium of cardiac CT is the assessment of gradients. Okay. Assessment of gradients, assessment of regurgitation, volumes of regurgitation. No way. Okay. So far is not into the business of cardiac CT. Good.
Okay.
You might see a valve area. You can check the valve area, mitral stenosis, aortic stenosis, prosthesis of obstruction. You can see it because CT provide you here some morphological data, but the gradient as is obtained in echo, you can get it in cardiac CT. Okay, so valve gradient measurement is out. So this is the hardware of cardiac CT. Okay, so it resembles any cardiac CT. You see the components of the hardware are the gantry. Okay, and this is the moving part, and the gantry houses 2 main components: the X-ray source on top and the multi-detector or the detector at the bottom. Okay, the patient in the table moves into the gantry. while the gantry is moving. So the patient will be scanned and the images are obtained. So the X-ray source, emit X-ray passes through the patient and it goes to the detector. So finally, the detector, what does it do? It gets attenuation map. So when this X-ray penetrates the patient, when it penetrates the patient, there will be different attenuation according to different tissue attenuation properties. So what you get finally is attenuation map. And this attenuation map is digitalized into the axial images we see in cardiac CT or any CT. Okay, as simple as that. Okay. طيب سؤال لكم جميعا. Any imaging technology, the diagnostic accuracy of which depends on resolutions. What types of resolution do you know?
Spatial resolution.
Very good.
Temporal
Temporal
resolution.
resolution.
Very good. These are the two most important, the spatial and the temporal resolution. The spatial resolution is the ability to differentiate between two closed dots, for example. Okay, so if we say that the spatial resolution is 0.5 millimeter, meaning what?
High resolution.
When I say 0.5 millimeter,
Can detect different points.
yes. When you
Different
say-
points.
There
is between them is 0.5.
0.5, exactly. So if it's 0.4, it will see them as one structure. They get fused together. So they will not be discriminated at two separate points. Okay? That's the spatial resolution. The temporal resolution is the ability of the imaging to scan a moving structure. So how fast the imaging technology can cope with a moving object so as to freeze it وما يحصل blurring in the image. Okay? So the temporal resolution is calculated in seconds and milliseconds. Like when we say the temporal resolution of the cardiac CT, let's say is 0.3 millisecond, مثلا, meaning that it can capture the images if they are moving fast as 0.3 milliseconds. Okay. Now, our problem in cardiac CT and what makes cardiac CT late to come into the cardiac business is the temporal resolution, basically. Because cardiac CT of the brain, of the cardiac, of the abdominal structures and all of that has been there since antiquity, you know. But cardiac CT started late 70s, early 80s and evolved rapidly in 90s and 2000. So it took us a time to get into the business of cardiac CT basically because of temporal resolution, because we are scanning a moving structure. Abdominal organs are not moving, the brain is not moving, but the heart is moving. That's why the technology has taken time to equip the machine and hardware with the ability to enhance the temporal resolution so as to scan the heart. Okay. So I won't go into the physics more than that. That's enough for you just to know that the temporal resolution depends on machine-related factors, which is the gantry, how fast the gantry can move. But we can also improve the temporal resolution by doing something else. And I wish you know this something else because that's important. Yani if you have a moving object and you want to enhance the temporal resolution, you either have to enhance the imaging temporal resolution or you slow down the object, right? Yes. So we can slow down the object and we do that by
the heart rate.
Exactly. Exactly. That's why beta blocker is so essential in CT lab. It's so essential. Give beta blocker 1 hour prior to the scan. The desired heart rate is 65 and lower. You know? Yes, lower than 65. So that's a way of improving the temporal resolution, decreasing the heart rate. Beta blocker is essential in cardiac CT. Okay. And of course, this is the topogram. So when you are scanning the heart, we are scanning the heart from the carina to the diaphragm. From the carina, as you see, to the diaphragm. You don't have to broaden your field of view more than that because of two reasons. Radiation exposure will increase as you increase the topogram. The other thing is that you are going to decrease your spatial resolution. So when you narrow your field of view, you decrease the radiation dose and you enhance the spatial resolution. But this one is not, this topogram or scout image is not used for all. يعني إذا كان مثلا the purpose of the study is cabbage graft. So you are going to elevate your topogram or scout to the clavicle because the graft comes from the lima and stuff like that. So you have to be up. So the scout image will be from the clavicle to the diaphragm. Okay. And you see here, this is quick, just quick. We won't dwell so long in this. You hear about gating. Gating means you adjust your scanning to ECG. So there is synchrony between image acquisition and ECG. Non-gating, you don't have that synchrony. In cardiac CT, we have synchrony, and that's important. This synchrony is so important to eliminate the motion artifact. Now we have prospective gating and we have retrospective gating. Okay. If I show you this one, the initial one is called retrospective gating. What does that mean? That means the machine is scanning continuously throughout the cardiac cycle.
During the whole cycle of the ECG.
Exactly. That's why you see this color, you know, it's always scanning. Now, prospective gating, the machine is triggered at a very pre-specified point in the cardiac cycle and is shut off during the rest of the cardiac cycle. This is called prospective gating. What do you think the difference between the two gating methods in terms of radiation dose?
Better perspectives are retrospective.
Exactly. 80% lower radiation dose in prospective. You know, type. What's the drawback of prospective gating? You have limited data to manipulate.
Yes.
So if there is a problem, exactly. If there is a problem in this specified, localized, limited data, you will have hard time. But in the prospective gating, you have data across different phases of the cardiac cycle. So if you have problem at one phase, you can go to the other phase because you have plenty of data to manipulate and reconstruct. Okay, so that's the trade-off. More data at the cost of more radiation. Okay. Now we said functional data, meaning contraction, relaxation, and opening of the valve, closure of the valve. Where can we get this one? In prospective or retrospective?
Retrospective.
Retrospective, exactly. Because retrospective, the data span the systole and diastole, while in prospective, you are just obtaining diastolic sample data, which is usually 70% of the RR interval, because 70% of the RR interval is the time of diastasis where the coronaries are the quietest. So we time our machine to operate during this time only and to be off in the rest of the cardiac cycle. So we have only diastolic data, so we cannot have functional data for systole and diastole. Okay. Now, what do you know about calcium scoring? What do you know about calcium scoring?
It reflects in coronary artery disease.
Exactly. This is one. It reflects coronary artery disease. Can it be used as a screening in asymptomatic patients?
According to the likelihood of يعني بعد ال greatest probability and the likelihood, you can go for calcium scoring.
Exactly. So coronary calcium scoring reflects the load of atherosclerosis. Okay? And coronary calcium is one of the greatest revolution in preventive medicine and preventive cardiology in particular, because it has been found to be one of the strongest predictor of outcome, far beyond and above the conventional risk factors. يبقى لو ما عندك أي risk factor بس عندك calcium score, bad. This is very bad. If you have so many conventional risk factor and zero calcium score, very good news. So calcium score can modify the risk factors. Okay. So it's advocated as screening test. Now the calcium score is basically, are you going to use contrast or non-contrast CT?
Non-contrast.
Exactly. We don't have to give iodine contrast at all. It's non-contrast because the calcium is seen so well by non-contrast. So all we have to do is we circle the calcium across the coronary arteries. Wherever we find calcium, we circle it. And we use the so-called Ajaston score. Ajaston score is basically the density score of the calcium times the area. So if you look at the green circle, what you have to do is the software will calculate the area of this calcium and the density of this calcium. There is a special way of calculating the density score. So you will have the calcium score in the green circle. Then you go to the red circle, to the blue circle, and you sum all these calcium score. That's the overall calcium score. Okay? This is calcium score. Good. Now, this is the cardiac CT, the axial images, which is called the source data. After you finish, that's what you get. Now you can reconstruct this data in different formatting, so you can get plenty of display modes. But this is the raw data. And you see the right side is on. Imagine that you are seeing the patient from the feet. So the right side is on this side, the left side on this side, you know, right? So this will be, just a moment.
Yes.
This is the right.
Screen will be the right.
And this is the left.
Yes.
Okay? This is the right and this is the left. And we are going into the heart craniocaudal. So from top down, okay? And from anterior, posterior. Okay. You probably see the coronaries now. You are seeing the coronaries coming. You see, that's the LADRCA coronary and all of that. I made it fast. It's not because meant to analyze anything, but this is how you get. And now see the last part, you see the abdominal organ. Here now, yes, yes. Now here we are in the abdomen. Finish. That's the diaphragm where we stop. We don't get any further. Okay. And we don't see much of neck structure because our scout, remember our scout start from the carina to the diaphragm.
Yes.
And we don't see much of the lungs, right? You see? Why? Again, because our scout is limited to the heart, so we don't include the entire lung fields. We go from the carina up to the diaphragm down, and we include part of the lungs on both sides, but not all of it, to minimize radiation exposure. Now, look at here. What do you think about this? Exactly. So what do you think about this LED?
The calcium scoring data?
No, this is called multiplanar or multiplanar reformatting of the LED. So the entire LED is stretched out. You can see all LED in its entirety. The arrow points to what? If I zoom it to you in, look here, I'm zooming in, I'm zooming in. You start to see what? Athyroma, you know, this soft or non-calcified athyroma with spotty calcification. Yani I will show it to you now, just a moment. You see this part here? You see, there is soft, beside the contrast, there is low attenuation part. This is athyroma. Again, here is athyroma. Okay. If you do CT for this patient, you might not find any significant obstruction. Yeah. But there is a huge amount of athyroma here. What's the difference? Why? Why this difference between invasive angio and CT?
Yes, more concentric or out of the.
This is one, but more importantly, the wall. The wall. The cardiac CT sees the wall. Invasive angio is blinded.
The lumen.
It just sees the lumen, what is inside the lumen. Okay?
Yes.
That's why cardiac CT picks up athyroma much earlier than invasive angio. Invasive angio, it starts to see athyroma when it's large enough to narrow the lumen. Like CT can see athyroma before it encroaches upon the lumen. Okay? That's why cardiac CT has a very high negative predictive value. Very high negative predictive value, meaning sensitivity is so high, meaning rule out is great. So when it rules out, it tells you no athyroma is there. You are confident no athyroma is there. So the negative predictive value in cardiac CT is approaching 100%. Okay? But it might overestimate. That's why the positive predictive value is not as high. That's the problem. Great negative predictive value, but not as great positive predictive value. One essential part of cardiac CT, which is coming strongly nowadays, is the characterization of the plaque itself. You know, now we are talking about, it's not about the plaque quantity, but what are the components of the plaque will decide or determine the outcome. So how much of fibrofatty core, okay, and stuff like that. So cardiac CT can show you the athyroma and the components of the athyroma. The fibrous tissue has a different attenuation than fat, than calcium. So theoretically and practically to a large extent, cardiac CT can characterize the plaque. Okay, so if there is attenuation lower than 30, this is athyroma, this is fat. Okay, and if there is calcium, you remember we have talked about calcium before. Will calcium increase the vulnerability of the plaque or not? That depends. That depends on how much calcium is there. If calcium is spotty, like the one we are seeing here, this is a spotty calcification, less than 3 millimeter, it's a high risk of rupture. And this is a vulnerable feature. But if it's larger than that, it might even be good news. Then it indicates healing of atheroma. So the calcium, you can't take it categorically bad or good. It depends on how, the size of the plaque and how the pattern of the plaque, whether it's spotty or large sheets covering the plaque. Okay. Now, there is another factor which is again important in atheroma assessment, that's called positive remodeling. Positive remodeling. And positive remodeling means initially when the atheroma accumulate in the wall, the entire diameter of the wall increases before it decreases. How can I calculate the positive remodeling here? Simply, I do this one. Let's say this part, I will see the diameter from here to here, and I compare it to a reference segment up there, normal segment, which is here. If it's more than the remodeling index more than 1.05, معناته I have positive remodeling. Positive remodeling is a sign of vulnerable plaque. Okay? So, generally speaking, cardiac CT provide you characterization and quantification of the plaque, which goes way beyond the quantity itself to the vulnerability and the component of vulnerability. So you will have more information than invasive angio can provide you about the plaque.
Excuse me, sir.
Sure. Yes?
If I take all the diameter, the diameter of the vulnerable plaque or of the plaque with the inner lumen, which is with the open lumen, the ratio will be 1 to 1.
لا,
I should
not
take
with not with the inner, with the wall. So you
ما عندي الطريقة بتاعت inner lumen أصلا هو it's not
لا,
an eye
you
بس
take,
هو it's not an OCT, it is an CT. It detects just the wall.
I know. But we take the lumen from the atheromatous side until the healthy part, as you draw here, your line before. Excuse me, can you hear me?
Yes, I do. Yeah. You see it like I'm putting now a reference point up in the left main, and this red bar is how I measure the diameter. Let me go for the segment down. The segment down is from here to here. From the outer wall to the outer wall. So now I compare the two. That will reflect the amount of positive remodeling. Okay?
Okay.
Yes. Okay. Now let's go further. And you can, this is again an RCA lesion, and you see the atheroma. Do you see the atheroma? Do you see the atheroma?
Yes.
Yeah,
Yes.
it's here. With spotty calcification. Now, there is actually a way of calculating the FFR, CT FFR, and it correlates so well with invasive FFR. So, you know, gradually, the cardiac CT is becoming one-stop shop where you can get everything. You can get the coronary angio, you can analyze the vessel, you can assess vulnerability of the plaque, you can assess ischemia, viability, and FFR. So there are a lot of things you can do by cardiac CT. Okay. طبعا الحاجات دي can you get it by cardiac MRI? No. Your cardiac MRI, when it comes to the coronaries, cardiac MRI is out. Yeah, cardiac MRI is out. Yeah. For muscle, for ischemia, for viability, for volumes, ejection fraction, gradients, stuff like that, yes, but not for coronaries. لكن الآن الcardiac CT for coronaries, and it is starting to take over or at least to compete with cardiac MRI في حاجات تانية, ischemia, viability, and stuff like that. Besides the refinement of coronary artery assessment. So it's not only morphological assessment. We can give functional assessment by FFR. So that will be great. You can have ischemia assessment by CT as well. Okay. Yeah. Now look here. What are we seeing? And you see how pleasant the cardiac CT anatomy looks like. You see the arteries in the first image, the axial images. In the second, this is called MIP, maximum intensity projection, and volume rendered in C, and indeed that's curve multiplanar reformatting, or CMPR. These are different display modes. So you can see the artery in different display modes. So you can, you know, face this workstation and you can reconstruct the raw data in so many different display modes. And it is recommended that you use more than one display mode so as to be sure that what you are reporting or interpreting is accurate. So the more you use a reconstruct, the better. Okay, but the axial images remain the most important source imaging or source data upon which you should rely heavily. Okay, as C, this volume rendered or 3D is great for what? Yes, volume rendering. It's great for what? It's great as a roadmap. It's a very impressive, pleasant picture. You can append in the report, even the patient can read. It's so pleasant, but it's not used for vessel analysis whatsoever على الإطلاق. لأنها ما بتوريك اللومين. اللومين you have to see by the NPR, MIP, and axial images and stuff like that. This one is great for road mapping. يعني anatomical relationship, the origin and the course of the arteries, and that's it. But not for exact quantification of stenosis. Okay, good.
Okay.
Now you see here, this is a cardiac CT. What is this? This is real-time images. This is cinematic images. You see, this is a cinematic images. So this is prospective gating, where the scan was on throughout the cardiac cycle. So we have exactly. We have systolic data and diastolic data, and when we fuse them together, we get cine. And you can, from this cine, you can calculate the ejection fraction, the diastolic volume, systolic volume, stuff like that. Okay. What is abnormal here? Tell me, what's abnormal in this cardiac CT?
Precardial calcification.
Very good. Thank you so much. Yes. That's a precardial calcification. But when we talk about precardial calcification, cardiac CT sticks out. You have to. This is the best modality of assessing calcium, cardiac CT.
Yeah.
Okay?
Yes.
Cardiac CT. Okay. Now, what do you see here? See? That's an RCA. And see, the RCA is seen in different orientation. You know, you can see the RCA in different orientation, so you won't be fooled by eccentric lesion or stuff like that. When you navigate the data by different display mode, you will be accurate in your quantification. And you see the corresponding coronary angio has showed the same high-grade high-grade atheroma. Exactly. Stenosis. Okay, now a question to you. What artificial valve is shown in this chest X-ray? Mechanical mitral, mechanical aortic, bioprosthetic mitral, mechanical tricuspid. Think of it.
طيب mechanical number one. الحاجة الثانية we have to draw a line between the sternum. If the valve above it, it will be a aortic valve. It seems like a mechanical aortic valve.
Mechanical aortic valve. Okay, any different opinion?
I think mechanical mitral valve.
Mitral valve. Any different opinion?
فضلنا نتركز بس ما تختاروا يا شباب.
Bioprosthesis with the ring.
Bioprosthesis. Who said bioprosthesis?
Yes, me.
منحة.
طيب يا منحة, bioprosthesis, that is so courageous of you because we are seeing a very dense structure there. How
Yes.
can it be bioprosthesis with this dense structure? Yani radio dense, this one, I show you. Kid, you have seen it, this part.
Yes. Yes.
Mhm.
It could be ring or some material using the.
Exactly, thank you so much. Yeah, that's the struts of the bioprosthesis. The struts of the bioprosthesis are radio opaque. The rings of the mitral and tricuspid valve are radio opaque. But this is bioprosthesis. If it's mechanical prosthesis, you will see discs. You don't see disc here.
Yes,
Yeah?
level.
Yeah, so this is bioprosthesis. Now, is it mitral aortic tricuspid? I think if you go by from the hilum downward, falling below that line, that's mitral. Okay, so this is
mitral.
bioprosthetic mitral. Bioprosthetic mitral. Okay, good. What is this? The one on the left.
It's cardiac CT showing the في dense في this cardiac CT في calcium.
Calcium.
Dense
Calcium.
yes.
Which one? Are you talking about the one on the left or the right?
On my right. اللي هي
on your right, yeah.
اللي عليها الارو. اللي عليها الارو.
Exactly. That is calcium. I agree with you. What about the one on the left? Huh? Yes?
Sure.
It's sorry again?
Stent.
Exactly.
Stent.
These are stents. Okay? In LAD and SIR. Exactly. Yes. So what's the problem? Are we going to do CT for stents? The problem of cardiac CT and which limits its diagnostic accuracy, especially with the stents and calcium, is the so-called blooming artifact or volume averaging artifact. So when you have a dense structure like stent or calcium, it blooms. It appears bigger than it actually is. And it might conceal or hide the lumen. So you won't see the lumen well. And the structure, the stent or calcium, will appear larger than it actually is. This is called blooming artifact. Okay, so that's why we have to be so skeptical in doing CTA for patient of calcium more than, let's say, 1,000, stuff like that. Sometimes they don't go for it because the diagnostic accuracy will be so low. And in stents, it's a problem. But the problem with the stent can be manipulated by reconstruction in special ways. But again, the stent itself has a lot to do with the image quality. So the larger the stent, the better, because if it's small, the volume averaging and blooming artifact will be more. That's why if a stent is more than 3 millimeter, it might still be feasible to image it with quite good accuracy in cardiac CT, but the smaller stents are not. So we have to be a little bit skeptical in imaging the stents, and when we have a large amount of calcium in the coronaries. These are the two caveats or the two limitations of cardiac CT. Now tell me, what do you see on the left image? You have the ascending aorta, right coronary cusp, left coronary cusp, non-coronary cusp, and anteriorly you have the pulmonary artery. I have the RCA and left main. What's the problem here?
The left main, it originates from the right coronary cusp.
Very good. And this is an important,
Malignant.
exactly, this is an important indication for cardiac CT, anomalous coronary arteries. Is it better than invasive angio or not?
Yes, better.
It's better because the
Differentiates
invasive
the malignant
angio,
force.
the invasive angio shows you the arteries without showing you the entire anatomy and the relationship. So you have to hypothesize about the course. But here you don't have to hypothesize about the course because everything is before your eyes. You can see the course between the aorta and the pulmonary artery, the so-called malignant course. You know, it might lead to sudden cardiac death and stuff like that. Yeah, so that's why for anomalous coronary artery disease, if you are suspecting that, I think cardiac CT is the way to go, not invasive angio. Now, what about the one on the right?
The RCA looks like from the left, huh?
Yeah, the RCA might be okay, which is here, but we have, you know, the left main is arising. Yeah, is arising anomalously. The left main is supposed to be arising here, okay? Now it's arising and it's coursing behind the aorta. That is retro-aortic course, which is not bad. Retro-aortic course, you know? Okay. And now what you see here is
the right coronary artery from the left, coronary sinus,
and coursing between
is the pulmonary artery and
aorta.
Exactly. So this is potentially a malignant course, right?
Yes.
Exactly. One other feature of malignant, one other malignant feature depicted in this image, apart from the course, is what? And some people think it's more important than the course between the two.
Origin from one sinus.
Not necessarily. No, not this one.
If it is intra-arterial, it could be malignant. Also, if it is a bridging or inside the muscle, this could be malignant.
Yeah, and I'm talking about other feature apart from the course between the major arteries. What other malignant feature is shown in this image? By the arrow. See the arrow. The arrow is pointing to what? Compressed, or you can say a slit-like origin and acute angulation. That is more important. Some people think it's more important than the course. The course itself is not malignant. It's the origin which decides about the malignancy. Okay? If it's angulated and if it's slit-like. So you see here, مثلا الآن إذا قارنت, look at this RCA. Look at this RCA. It's coming with an angle. Look at it here. It's coming more acutely and it seems like stenosed at the origin. It's slit-like origin because of the acute angulation. And this one, which might lead to ischemia, especially during exercise, when the aorta dilates, it leads to more compression at the origin. That's why, as part and parcel of assessment of anomalous arteries, is to include the characteristic of the origin, whether it's slit-like and the angulation, in addition to the course itself. So the malignancy is not about the course itself, but the characteristic of the origin as well. Okay? Okay. What is this? About the assessment of metallic valve for mobility is usually done by floor. It's usually by floor.
Yes.
Or TAE, لكن cardiac CT is coming into business as well. So you can assess mobility of the metallic prosthesis quite well by cine images, the functional data you get during systole and diastole. Okay? Okay. And as you see here, we have an aortic valve which is obstructed by a thrombus. You see the thrombus, this hypodense or hypoattenuation shown by the arrow. Again, this is an obstructed valve, and the arrow is showing a thrombus, this hypodensity below the valve. Okay. Now, TAVI. طبعا يا اخوانا, structural heart disease has activated the field of imaging really a lot. يعني التافي غيرت في انه يفترض الناس تعمل شنو في الإيميجينج. الvalve involved and stuff like that. So with the advances in the interventional and structural heart disease, there will be parallel advances in the imaging to cope with the necessities and requirements. الآن التافي إن شاء الله يعني يكون في تافي قريب في السودان, لأنه I think they are arranging for a TAVI workshop and stuff like that soon. A TAVI needs cardiac CT. Can we do without cardiac CT? Yes, we can. We can. لكن الcost is really high, لأنه you have to do transthoracic echo and TE with 3D formatting and analysis of diameters بطريقة, ومهما عملنا the accuracy of TE compared to the cardiac CT, يعني it's like 10% lower in accuracy. They're in the best hands يعني when we do TE. ولذلك الcardiac CT, if available, it's the best way to go. Okay? A TAVI protocol, basically, if you look at these images, what you have to do is, لأنه مشكلتك الأساسية في التافي شنو؟ The axis, the size, and the deployment. These are the three. How you go in, how you size the valve, and how you deploy it. So you need parameters and data to help you do that. واحد منهم assessment of the peripheral arteries. Peripheral arteries has to be assessed عشان توريك الأكسس حقك كيف هو. Okay? How much calcium, how much diameter of peripheral vessels, how much tortuosity, each of which is going to affect your axis. So you have to give data about axis. Sizing, you have to give perimeter sizing, amount of calcium, and important feature is this one, the height of the takeoff. يعني الvalve هيدخل هنا, هيدخل في المكان ده. I need to know when I put that valve, how is the height to the left main and how is the height from the RCA. A safe height is something above 10 millimeter. يعني إذا كان في short height of left main or RCA, your TAVI valve might occlude the coronary. وتبقى big deal. So Calculating the height takeoff is important. يبقى بالتالي التافي protocol is looking for axis peripheral vessels and how they look like in terms of calcium size and tortuosity. You evaluate the size of the aorta and aortic valve, the sinuses and the LVOT and the calcification, and you assess the height of the takeoff of the coronary arteries from the annulus. Okay, this is what you do, and this is now it's important. Yani the vast majority of TAVI patient relies on CCT data, not on echo data. We are trying to take over from CCT, but we can't yet. يبقى معناتها a CCT is the default. You go for T if you don't have CT facility. ممكن. لكن you have to be aware there is a margin of error at least 10% when you are using T and you do it the best. And cardiac CT is the best here in this quantification and parameter assessment. Again, there is valve-involved implantation, another interventional procedure done for degenerative bioprosthesis. You can put a valve in the degenerative valve. You also have to use CT for assessment of the size of the bioprosthesis, and they can do even simulator where they put the new valve and you see how this new valve is going to affect the LVOT. Is it going to do obstruction, and will that obstruction be severe or not? So again, cardiac CT gives data about valve-involved implantation. Yeah, good. Now, this is a 52-year-old woman with hypertension and dyslipidemia, present to emergency department with worsening chest discomfort or minimal exertion. ECG non-diagnostic, 2 sets of troponin negative. She underwent cardiac CT. And this is the cardiac CT. What do you see?
proximal RCA atheroma.
Exactly. Is it appropriate to do cardiac CT in this patient? Yes, you can. It's appropriate. Yani if ECG is normal, cardiac markers are normal, and the patient is intermediate risk, you can do cardiac CT. And this is the cardiac CT. What does it show?
Proximal RCA atheroma.
Okay. Severe stenosis in the mid RCA. Exactly. That's the severe stenosis in the mid RCA. Good. Okay. Just a moment. Okay, let's go further. Now, what do you see here? I'm showing you arrows. That is cardiac MRI. This cardiac MRI is showing you an abnormality, and I want you to guess what is it. That's ischemia, amyloid, myocarditis, or hookup. Again, look at it here.
Can you see?
Sorry?
Okay.
You see here, usually this is delayed hyperenhancement pattern. So the delayed hyperenhancement gadolinium is not seen this way. That's an abnormal. It accumulates in the entire endocardium. So there is global subendocardial hyperenhancement. What's the meaning of this?
Yes.
And you see even the enhancement is spreading into the atria as well. So that is what?
Yes.
What is it? Amyloid, yes.
Amyloid.
This is so characteristic of amyloid. Very characteristic of amyloid. Now, CMR. What should we know about CMR for the sake of the board? We just have to know this one. This is slide only, I think. But of course, we know that cardiac CMR is the best, or now the gold standard of viability assessment. And it can settle disputes about valve quantification. When the echo is not the final answer, you can go for CMR. لكن أهم حاجة بتعملها CMR is the tissue characterization. يعني إذا عندك mass, you can see the characteristic of the tissue in that mass by CMR. And the other thing is the hyperenhancement pattern for cardiomyopathies. And look here, subendocardial enhancement. When you have infarction, you look the first one, this one. This one. Ischemia starts subendocardial. You agree with me? Yani if you have ischemia, it starts from the inner wall coming outside. So it's called endocardium epicardial. It starts from the endocardium and it goes toward the pericardium. This is called ischemic wave front. يعني إذا عندك ischemia, أول part that will be affected by the ischemia is the endocardium. بعدين followed by the myocardium القريب من الاندوكارديوم ثم the mid myocardium ثم epicardial myocardium ثم كده. You agree with me؟ صح كده يا اخوانا؟ ها؟
Yes.
I lost. اوكي معاي يعني معاي. كويس، مرات الواحد بيكون عايز يعرف الناس لسه معاه. تمام. So this is subendocardial infarction. Look at look at the other image. This is transmural infarction. Transmural because it affects the entire wall. The entire wall. So the entire thickness is affected. This is non-viable part. Basically, this is non-viable. Now, when you look at the amyloid, amyloid will lead to global subendocardial hyperenhancement. So the difference between amyloid and ischemia will be patchy subendocardial hyperenhancement that correlates to the territorial arrangement of the coronaries, while in amyloid, it will just be global. It just be global. Cannot be explained by ischemia. So that's amyloid. Now for cardiomyopathies and myocarditis, it is mid-wall or epicardial or special pattern. So what you have to know, subendocardial hyperenhancement is infarction till proven otherwise. The only exception to that is when it's global. That is characteristic of amyloid. In cardiomyopathies and myocarditis, the pattern of delayed hyperenhancement is mid-wall or subpericardial. Mid-wall or subpericardial, like what is shown here. Okay?
Okay.
Okay. Now, what is this? This is a question. The SPECT is best read as normal, high-risk scan, inconclusive, increased lung uptake, inferior ischemia. So you can zoom in and see. So what do you think?
Look like normal, so?
Exactly. This is so normal.
Yeah.
If I ask you what is this called, this one, short axis, right? This is short
Yes,
axis.
short axis.
Yes.
Yes. And what
Yes.
is this called?
Horizontal.
Vertical
Horizontal.
long axis, vertical long axis, and the one below, and the one
Vertical.
below,
The other is horizontal.
and
It's
the
horizontal.
lower is the horizontal long axis. Okay, so in this formatting, you are gonna
Yes.
see the all segments. Okay, all segments of the heart, 17 segments or 16 segments. You are gonna see them here. So this is a normal scan. Okay. Now let's see this. The scan on the left indicates breast artifact, non-viable apex, TID, non-ischemic cardiomyopathy, LAD ischemia.
صغيرة شديد يا دكتور حاتم.
Ah,
اوكي كده كويس.
I agree with you, yeah. What do you think?
They put the pet في الانتيريور there is big defect during rest and stress.
Very good. Yes. Yes. So you have in the anterior wall, you see here, مثلا, this one here, the anterior wall, and also in the apex. Anterior wall and apex. So this is what?
disc.
Sorry? Again?
During stress, yes.
طبعا sometimes بيكتب لك stress rest، لكن إذا ما كتب لك the upper row usually the stress. The one on top is the stress. Okay? يبقى هنا I have reversible ischemia, right? There is reversible on the anterior wall and the apex. So this indicates LAD ischemia. That's LAD ischemia, exactly.
Yes.
Type. Now this is SPECT and PET. Look at them, stress and rest. All is true about the difference between PET and SPECT, except PET is better image quality. PET gives the absolute perfusion map. SPECT has more artifacts. SPECT portfolio has no viability assessment. هي طبعا مرات يا اخواننا يعني the art of answering these kind of questions sometimes you don't know لكن حاجة is sticking out even if you don't understand this SPECT has more artifact or absolute and relative perfusion map, you know that in SPECT we can assess viability, صح؟
Yes.
Yeah. This is in SPECT we can assess viability, so we cannot say SPECT has no viability assessment. So we can assess viability assessment in SPECT. So now how can we assess viability in cardiology? We can assess it by SPECT, by PET, by echo, by MRI, and emergingly by cardiac CT. If في 5 modalities by which we can assess viability. The golden standard of which is? The gold standard is? The gold standard of viability assessment. PET يعني لو كان مثلا maybe 10 years ago the answer would have been PET. لكن الآن CMR cardiac MRI. Cardiac MRI is the gold standard of viability assessment if available. إذا ما available, you can use the others. Okay? Besides, طبعا, it's not only the gold standard, but it's non-radiation imaging, and that's so important. Non-radiation imaging and gold standard. Yani the diagnostic accuracy of viability assessment in CMR corresponds so good with the histopathology itself. يبقى diagnostic accuracy is unbeaten by the rest. Besides, it's non-radiation. Okay, so if you have CMR, go for it. If you don't, then expect PET أو echo أو حتى cardiac CT might be used. Okay. طيب, I want some of you to explain to me where there is viability and there is no viability. Which one has viability? Which one has no viability by using PET here? And by the way, for the sake of the exam, I think this is the only thing you have to know. Sorry?
Non-viable, inferior, RCA area.
اتحد no viability because it is a fixed defect, so it is not viable.
طيب.
The one on yes.
والفيس
the
one.
above the defect is not fixed. You know, during rest.
هي طبعا هنا ما في rest وستريس، في ده كله rest scan. During perfusion, there is perfusion scan on top and metabolism scan the second row. So this is comparison between perfusion map and metabolism map. طيب. This is PET evaluation of viability. What does PET do? Basically بيعملوا perfusion map بالrubidium. They inject rubidium and the perfusion will appear like it's in here. Now they give fluorodeoxyglucose as a metabolic tracer, the second stage, and they see how it feels in the heart. Viability, what does viability mean? Viability معناتها it's still actively metabolizing tissue. يبقى if I demonstrate إنه في perfusion defect لكن on metabolism scan it appears as metabolically active, I would conclude that is viable. بالضبط ده الحاصل هنا. الحاصل هنا إنه this part for example is no perfusion. لكن when I give metabolic tracer, it's active. So no perfusion, but metabolically active. This is called mismatch. Mismatch between the perfusion, which is absent, and the metabolism, which is present. Mismatch indicates viability. Now look at the lower image. Apex, no perfusion. I give metabolic tracer, no metabolism. So no perfusion and no metabolism. This is perfusion metabolism match. This is non-viable. This is non-viable. Okay?
Scarred myocardium.
Okay, scarred myocardium. Now the question is, look at this one, sorry. Look at this part and tell me why, and I need an intelligent guess. If you look at this part here, no perfusion, and there is metabolism. Now look at the septum here. There is perfusion, but no metabolism. Why?
Hibernative.
لا, الهايبرنيتنج هو ده. الهايبرنيتنج اللاترال wall هنا. And we demonstrated why it's hibernating. Because no perfusion, لكن there is metabolism. لكن نحن we are talking about الاريا اللي كان فيها perfusion ظهرت انه كانها ما فيها metabolism. If this is normal or abnormal?
Normal.
Why?
No.
Why it's normal? لأنه the normal myocardium, the normal perfused myocardium is not using glucose for metabolism, is using free fatty acid. It uses glucose only when it's ischemic. بالتالي لما يكون normally perfused and you give FDG, it will not be uptaken by the normal perfused myocardium. Okay? عشان كده don't focus على normal myocardium. Focus على abnormal perfusion and compare the abnormal perfusion في الperfusion map مع abnormal metabolism في metabolism map. هنا بس you compare this one, this lateral wall, sorry. This lateral wall, I'm so sorry, I don't know why it's not working. This, lateral wall مع metabolism which is uptaken now. يبقى there was no perfusion and now there is metabolism. It's ischemic hibernating myocardium, that's why it's using glucose. Okay, that's why it's using glucose. لأنه the metabolism of glucose needs less amount of oxygen لأنه it can go by anaerobic glycolysis. That's why when the myocardium is ischemic, it resorts to metabolizing glucose instead. لكن free fatty acid, the metabolism gives more ATPs, لكن at the expense of using more glucose through beta oxidation process. That's why it needs to have normal and normally perfused myocardium عشان use the free fatty acid. لكن this is the energy, the normal energy substrate of the normal heart is free fatty acid and not glucose. Good?
Sorry, Dr. Hatim.
Yes.
In the lower imaging, the perfusion area is the same area as the metabolized area.
Yes, exactly. So no perfusion and no metabolism. So this is perfusion is matching the metabolism. This is non-viable. Okay.
No, I mean the perfusion, as I understand, the perfusion area should not appear in metabolism. Yes?
Yes, the metabolism is different. Yeah. Yeah, exactly. And that's why, if you look here, مثلا, show you this one. If you look at this part here, this is normally perfused, لكن it's not taking much of glucose. This is normally perfused, but when you look at it here, it's not taking glucose because these are normally perfused and they are using free fatty acid. لكن the most important part is the non-perfused area, which remains non-metabolic area, that is match, that is non-viable. Okay?
Okay, thank you.
Excuse me, Sarah.
Sure.
If it is viable, how I can differentiate between mismatching due to health tissue or mismatching due to low metabolism?
Low metabolism. What do you mean by low metabolism? What do you mean by low metabolism? هي طبعا نحن زي ما اتفقنا انه in the perfusion map هنا you don't have to focus on the entire perfusion map to get confused. Where is the perfusion defect? Tell me, where is the perfusion defect? Inferior wall and lateral wall. You agree with me? In the upper row. Inferior wall and lateral wall. Now look at the metabolism and tell me, what about the metabolism of the inferior wall and lateral wall?
There is good metabolism.
Exactly. So what I have demonstrated here is I have no perfusion, but I have active metabolism in the inferior wall and lateral wall. This is viable wall. This is viable wall. Okay, just a moment.
It is clear.
So do we get this one? Okay. So now tell me here, what is true about valve flow dynamics? Decreased heart rate tends to increase the aortic gradient. Increased heart rate tends to decrease mitral valve gradients. Increased heart rate tends to increase mitral and aortic gradients. Increased heart rate decrease mitral and aortic gradients. No relationship between the gradient and the heart rate. Which one is true?
Increase heart rate, then increase mitral and aortic gradient.
Increased heart rate tends to increase mitral and aortic gradients. Right? Do we all agree with this? Okay, so you all agree that that's right answer? Right. Okay. I have a different opinion.
I think B here decrease. لأنه أنا I decrease the gradient between the two chambers.
And I'm gonna choose this one, whether you like it or not. Strange, right? Yeah, طبعا
Right,
we know,
increasing the volume.
yeah, we know
Only
so
mitral.
well.
Yes, increase the time of filling.
Exactly. يعني we know that إنه gradient is flow dependent. The more of flow, the more of gradient. Now, مثلا لما يكون عندك aortic valve وتكون في tachycardia معناتها شنو؟ معناتها short diastolic period, and according to the Starling law, a systole depends on diastole. So if I have short systole, I have less forceful, if I have short diastole, I will have less forceful systole. بالتالي الفلو مع التكيكارديا during systole حيكون low, the gradient tends to be low. While in bradycardia, you have longer time for diastolic stretching and filling. بالتالي I expect the force of contraction to be strong, and flow to be high, gradient to be high. مع mitral valve, it's the opposite. Bradycardia decreases the gradient, tachycardia increases the gradient. Okay? Okay? Guys, are we fine here?
Yes.
Tamam. Now, the coloring modes from the mitral inflow shown in the slide interprets as, what do you think is going on here? This is a mode of the mitral inflow. I'm gonna zoom it in. I'm gonna zoom it in. What do you see? It's a bit tough, I know. Let's try to guess.
Late systolic. The jet of MR late systolic.
The jet of MR is late. Late what?
Systolic.
Systole. لا هو if you look at the MR which is here, this MR, طبعا الام mode الcolor m mode, it shows you the time relationship even better than 2D color. فبالتالي هنا I'm seeing the MR here. That's the MR. لكن when you time it, when you go into the ECG, that is not a systolic MR, that's a diastolic MR. So I have the
diastolic MR.
Exactly. And this diastolic MR, when you follow it down here along the tracing, you see is minimized and disappear. When you correlate that with the ECG, you see when I have diastolic MR, the ECG is different. That's an ECG effect on the diastolic MR. When you have phase degree heart block, for example, you tend to have diastolic MR sometimes. And when you restore the PR interval, that PR will diminish or go away. Okay, so that's what is shown in here. A bit tough, that's why don't worry about it. It's not exams kind of stuff. Now, what do you see here?
Sorry.
Yeah. You want me to go back?
I didn't see the ECG.
Yeah. What we said here is we have this arrow. This part. Sorry. This one here is diastolic MR. Let's time it. Let's time it. When I go up in the, that is not systolic MR, that is diastolic MR. Okay? Diastolic MR. So we have diastolic MR, and when we see along the tracing, it tends to decrease and go away. Why? Because the ECG was different in this portion than the second portion. Here was sinus rhythm with normal PR interval. Here it was complete heart block with prolonged PR interval. Complete heart block with prolonged PR interval can create diastolic MR, and it disappears when you restore the sinus rhythm and the normal interval between the segments. Okay. Okay. Now, X-ray, what does it show? This X-ray, what does it show? So you don't see the precordial calcification here? There is precordial calcification.
Yes,
no?
it shows.
Yeah,
Yes.
this is precordial calcification. Like, I forgive you if you don't, because the AP and PA orientation might miss the calcification, and lateral is much better. So when you want to see the calcification the best by X-ray, choose lateral. Okay, lateral will show it better. Lakin, if you have to choose from all cardiology imaging modality, the best to evaluate for calcium and precardial calcification, which one you are going to choose?
Cardiac CT.
Cardiac CT, exactly. Yes, type. What intervention can potentially change the mitral inflow pattern as shown in this image? Before and after. What is before and after here? Diuresis, control of severe hypertension, correction of anemia, all of the above.
All of the above.
Can you explain?
This mitral inflow before it's showing a restricted pattern of
yes,
dysfunction.
very good. Very good.
So diuresis can treat it or reduce the grade of the diastolic dysfunction to a lesser degree of to the normal.
Very good. Yes. So diuresis will decrease the diastolic dysfunction. Control of hypertension will improve diastolic function. Correction of anemia will improve diastolic function. So this restrictive pattern, which is shown before, and it improved in grade from grade 3 to grade 1, meaning there is some management employed. It can be any of these three.
Yes.
Now, the image on the left shows contrast CT, aneurysmal circ, artifact, MAC, precardial calcification. So what is this?
What is MAC?
MAC, yes. This is exactly at the
mitral annular
calcification. Exactly. This is a significant amount of MAC, but because cardiac CT is best in depiction of calcium, it looks like that. Okay, so this is mitral annular calcification. This is non-contrast CT. It is non-contrast. No contrast is given yet. Okay, now this is what do you think about this one? There is a bovine arch, anomalous left main, apical thrombus. There is indicator of severe aortic regurgitation. Anybody can take this? Bovine arch means what? Bovine arch means you know that بالعادة normally, if that's the arch starting here, the first branch is the brachiocephalic or innominate, which branches into two or divides into right common carotid artery and right subclavian. Then you will have the left common carotid, then you will have the left subclavian. So it will look like that. 1, 2, 3, 2, and 3. Okay. The first one is the innominate, which divide into right common carotid and right subclavian. And the one in the middle is the left common carotid, and the last one is the left subclavian. Now, the bovine part means what? The common carotid artery, the left common carotid artery, is a branch of the brachiocephalic. Okay? It's not separate, arising from the arch separately. That's bovine, but it's not shown here actually. This is not the case here. So what do you think about this one? Anomalous left main, you see the left main is here, and I see that this left main is arising normally. There is LV apical thrombus. What is this here? Is it thrombus or something else? This part, is it thrombus? This one here. No, this is papillary muscle. Okay, this is papillary muscle. So we don't have thrombus, but we have what? We have severe dilatation of the aorta. And when you look at the aortic valve, you see there is malcoaptation. You see the aortic valve here? Look at the aortic valve. It's not coapting because of the stretch of the dilatation of the aorta. So there is an indicator of severe aortic regurgitation here, okay? So the assessment of the root and the aorta and stuff like that by cardiac CT is really great. Right. We are approaching the end. So now, what do you think here? What do you see? What's the arrow points to?
Bridging.
Sorry?
Bridging of the
exactly. Bridging.
Bridging.
Yeah. I want to ask you a question. How common bridging is by cardiac CT? Yani, according to cardiac CT, how much frequency they find bridging of any degree? Guess. Guess.
I think very large, more than 50.
Exactly. More than 50%. So it seems like normal anatomical variant. That's why when you are describing bridging, you don't go as bridging. You have to tell about the degree of bridging by telling how much it dives into the muscle and how long it remains tunneled inside the myocardium. Maybe that will be has some clinical significance, but bridging as such is not usually clinically relevant. Now, this abnormality is rare in cardiac CT, and we said no, it's common. Any degree of this abnormality is very common in CT. Yes, it's very common in CT. The proximal calcification does not impact evaluation.
No.
Yes.
No.
This abnormality is
Related
commonly
to
associated with symptoms.
No.
It
is not commonly associated.
Exactly. It's commonly not associated with symptoms. Exactly. Now, what is this? This is there is a pneumopericardium, which is here. We think this is pneumopericardium, this here. Is it a pneumopericardium? What is this structure? Trachea. This is the trachea. Okay? Yeah, exactly. So, no pneumopericardium. There is a 50% chance there is bicuspid aortic valve. There is severe aortic stenosis. There is a thrombus in the right innominate artery. This one. This one. There is calcification, but no thrombus. So which answer is right here?
B.
50%.
Exactly. Yeah, because this is coarctation of the aorta, as you see here. That's coarctation. It is clear coarctation. Okay. Now, which of the following is incorrect? There are 4 graphs shown. One SVG is occluded. This is a coronal projection. There is REMA to LAD. There is occluded SVG, most likely to diagonal. A bit tough.
Yes.
طيب أول حاجة
until the apex, it could be a limb.
How many graphs? Look at them. How many graphs?
Yeah, it's
One.
This is lima to LAD.
The
This is the first one.
You see the lima? Lima to LAD. It's here. We have SVG to RCA.
Yes.
We have SVG to somewhere else. And we have an occluded graft, this one. This one is occluded graft. Okay. So we have 4 grafts, 1 arterial, 3 SVGs. Okay. So if we have to choose here, I think which one is incorrect? 4 graft, yeah, this is correct. 1 SVG occluded, yes, this is correct. This is coronal projection. طبعا in the imaging, we have axial projection, and we have sagittal, and we have coronal. Sagittal is from left to right or right to left, coronal from anterior to posterior, and axial from top down. So this one is coronal because it is from anterior to posterior. Okay, so that's a coronal projection. There is REMA to LAD, no, there is LEMA to LAD. And there is SVG occluded, yes. So the right answer here is REMA to LAD, which is not right, it's LEMA to LAD. Good? Now, there is a motion artifact. RV is likely to be dilated. BMP is likely to be normal. The patient should go for emergency surgery. There is SVC thrombus.
RV is likely to be dilated.
Okay. Why? What do you see here?
Is the filling defective pulmonary
saddle shape.
embolism.
Exactly. This is saddle shape pulmonary embolus. Exactly. So RV is likely to be dilated. PMP is likely to be high. Patient need lytic therapy or angioplasty or angio interventional angio, but lytic therapy, the line of therapy. And SVC thrombus. Where is the SVC? Here. The SVC is here. I'm showing you this. You see this one? This is the SVC. And there is a filling defect. That filling defect in SVC is so common. Why? Because you are giving contrast followed by a saline flush. So there is mixing of contrast and saline, and it gives that impression. So this is not a thrombus. This is mixing of contrast with non-contrast. Okay? Good. Now, which of the following is incorrect? RV is dilated. There is large ASD. LV cavity is small. Surgery is the only option. What are we seeing here?
Dilated right side.
There is dilated RV, exactly.
Yes.
And
there is an ASD.
There is an ASD, exactly. That's the ASD
and the cavity
here. And the RV cavity is small because of compression from the dilated RV.
Yes, so the incorrect answer is surgery is the only option.
Yeah, can you explain? What other option do we have?
Closure device.
Exactly, exactly. Yeah. Now, the arrow points to lipoma, ischemia, trabeculation, late pass contrast, thick pericardium. Look at it closely.
Thick pericardium.
No.
No.
Trabeculation. Late pass.
Ischemia, exactly. This is ischemia. You see, because it is subendocardial hypoattenuation. That part is not taking the contrast because no perfusion. That's why it appears hypoattenuated compared to the nearby myocardium. So that's ischemia. If you apply late imaging, you might see that it will fill with contrast. And that will be infarction and stuff like that. We are not going to go into the details, but this is how ischemia could appear in cardiac CT. Okay. Now, this image is an axial image, 4D image, requested by EP team. The LA is dilated.
Here, volume rendering image is 3D or 4D.
Very good. Yes. So it is 3D, not 4D. What's the meaning of 4D? وفي حاجة اسمها 4D حقيقة هي مخترعة ساي صح؟ لأنه نحن we have 3 dimension. ال 4th dimension is time. يعني لما تقول 4D معناتها 4D in echo, 4D in CT in MRI معناتها شنو؟ معناتها 3D in real time. يعني 3D moving. Cinematic 3D. دي بيسموها 4D. Okay? Yeah.
The right answer is C, requested by the EB team because it is mainly directed or mapping this volume rendering.
جميل جدا يا دكتورة. That is so right. طبعا cardiac CT is requested by EP to map the anatomy of the pulmonary veins prior to ablation. This is so important لأنه they need to know exactly how many and the ostia and the entrance so they ablate fully and completely without residual miss. Now, if there is a supernumerary artery, which vein, for example, they might miss it if you don't tell them sometimes. So a CT will provide them with enough data to decide about the amount of ablation and the completeness of ablation. Okay, so this is important. Now, this CT and the correlative angio, you see the CT and the angio, the same for the same patient. it shows the low negative predictive value of cardiac CT. The angiogram depicts the wall and the lumen. CT angiogram depicts the wall and the lumen. Angiogram does not miss positive remodeling.
عايزين true or false?
عايزين true.
Okay. So, نبدأ بتحت. Angiogram, it does miss the positive remodeling because it can be assessed by the CT.
So does the invasive angiogram does not miss positive remodeling?
No, it does miss.
It does miss, exactly. It
Yes.
does miss.
Yes.
Tamam.
About CT angio depict the wall and the lumen. No, it just depicts the lumen. طيب. Sorry, the CT depicts the wall, not the lumen. Yes.
Thank you so much. Yes. So this is the right answer. Look here. Yani, when you look at the CT is showing you a bulky atheroma around the contrast. That is not shown in invasive angiogram because the cardiac CT sees the wall and the lumen, and coronary angiogram sees only the lumen. Okay?
Yes.
Yes, and that is why the CT has high negative predictive value. يعني the invasive angio can miss the wall, بالتالي ممكن يكون في atheroma and the angio is reported as perfectly normal. لكن الكاردياك CT if reports إنه الangio is perfectly normal معناته it's perfectly normal. Okay? لأن معناته it has inspected the wall and the lumen and nothing is there. So that's a great degree of accuracy. Okay? So I think that's it, and thank you. This is the end of the session tonight. Next Saturday. Thank you so much.